Hi everyone, Sue here, and I thought I would just take a minute to talk about something really near and dear to my heart. This idea that not only can we be extremely valuable to the team because we are critical thinkers and we go through that clinical inquiry process, but that also sometimes our thinking can have biases built into it, and that these biases can actually put our patients in real danger. Biases happen in a variety of ways. There are many, many listed, but I want to just take a few minutes to give you some examples. And when we think of high acuity and how we're practicing in rapidly changing environments, how these might be really important. Let's start by asking that question of what are thinking biases? And that what they really are is they're traps. They're traps in how we think. And they're just errors that we make in our thinking when we don't follow that sort of rigorous analytical step-by-step process, observing information, making sense of what that information means, determining how that relates to a situation, how we and what kind of information we even collect. Is it through direct sources? Is it through indirect sources? So communications with patients themselves, communications with patients' relatives, that transfer of accountability and the information we learn from that. What is the accepted evidence and what is changing evidence? And what are sometimes accepted or taken for granted ideas that are really not evidence-based at all, or often have been part of the past and part of past practice, but no longer evidence-based. So these thinking biases are really important because they are so much part of, for most of us, part of our lives in a whole bunch of different ways. But in our practice, they are a hazard to our patients. And that's why it's important that we shed some light on them so that we can be aware and be reminding ourselves sometimes that we need to avoid that. And I'm going to try to give you examples of the thinking biases that I'm going to talk about, just because for me that helps to make sense. And confirmation bias is a really important one, that we believe what we want to believe. So we have an idea, and then all of the information that we see, we add to that idea. That information continues to confirm our pre-existing belief. So, and we tend to then favor the information that supports the idea we already have, that confirms that idea, and we don't pay attention to the other information. And for those of you, I'm going to bring us back to Lewis Blackman. Do you remember that situation? And I hope you've listened to that YouTube video where his mom really shares this story of, he had that thoracic surgery, or it was a surgery on his sternum. And there were many things that went wrong, but by the time he had gone in, had surgery on Thursday, by Sunday morning, he had an acute episode of terrible abdominal pain, nowhere near where his sternum surgery had been. The nurse who came in to see him right before change of shift was very concerned, went back out to the nursing station quickly, and then came back in a few minutes later and said, it's okay, it's just constipation. Now he was having acute abdominal pain. And in the time between rushing out and concern and coming back, she hadn't assessed him in any way. No one put their stethoscopes on his belly. Nobody tried to assess any further, but now they had made a diagnosis, a determination. It was constipation. And as the mom says, that's the diagnosis that stuck. So everything that they saw from that point forward was related to that diagnosis. So the fact that he was nauseated, well, that's related to the constipation. The fact that he was having so much pain, well, that's related to the constipation. The fact that his bowel sounds are diminished, well, that's related to the constipation. So they took new pieces of information and they kept adding them to the idea that they already held, instead of looking at new pieces of information. And every time we acquire new information, saying, how does this relate to what my preconceived ideas? And does this change in any way the clinical picture that's forming? And that is so really critical. It's critical because, as we know from that Lewis Blackman situation, Lewis died. This confirmation bias closes us off to being really able to determine changes in patient condition and to prevent errors, or if we see a patient who may be in the early stages of deteriorating in some way, being able to escalate, and or even if we've moved beyond escalation, being able to rescue. And so we really need to be very careful. Confirmation bias is when we've already got that pre-existing idea And often where we see that is when we treat based on diagnosis. This person has a gallbladder, is having a gallbladder attack, is having, has cholelithiasis. And so that's why I'm seeing this kind of pain. Well, are you sure that it's that kind of pain? Because there's lots of other things that could present in the same way. And I think of one day in the emergency department where I had a patient who came in and the assumption was, it was a woman in her early 40s. The assumption was she had previously had cholelithiasis, had not yet had surgery. Assumption was she was having a gallbladder attack with, terrible left upper back pain. And in fact, she had a ruptured ectopic pregnancy that presented very similarly. So it's so important that we recognize that we don't prejudge what's happening, that we take information that we see moment by moment and assess it independently. Authority bias. Oh my gosh, this is a really important one. Do you ever feel, am I the only one who, I remember so vividly feeling like a fraud when I was a new nurse, thinking everybody knows everything, and really I do not even know the first thing, and I feel constantly like I'm on the edge of a cliff about to fall over. It's a lot of responsibility. People's lives and their dignity are in our hands. It's so important that we recognize the breadth of what we're doing, but also that we are accountable individually. And so authority bias is something that's easy to fall into, particularly for novice nurses, but even as you move through your careers. And that's the idea that the person with most authority is the one who has got to be right. So whether that might be a charge nurse, a nurse educator, a primary care provider, I am definitely not a physician basher, because we all work as an interprofessional team, but really important to recognize sometimes that's a physician, sometimes that's a nurse practitioner. I worked in the States for several years where I was working with physician assistants. Whoever is the primary care provider, whoever is seen as having the authority in the situation, may be the person who is holds all the cards. They're the one that we think has the best judgment in the situation. That cannot be held as true. Everyone brings their own knowledge, skill, and judgment, and everyone is accountable. And it results in ideas coming only from some members of the team. So it's the senior members of the team. Their ideas are more important than everyone else's ideas. Really important as I think about my own career, and I'll share a story again, being a very, very new nurse in the emergency department, almost like within my first few days there, and having an assignment of patients in an observation area. So they were stable, they were admitted, waiting for beds. And I went to assess a patient. The patient was hypertensive, had significant amount of congestion with crackles in his lungs. Ultrasound was okay, but he was working hard to breathe, and we're going to talk about that. I really love talking about that. And so I was concerned about his condition, and I called his physician, his admitting physician. Within about 10 minutes, the charge nurse, and again, remember, this was my first few days in the ER. The charge nurse called out very loudly, who called this admitting physician? And I said, oh, that was me. And she let me know that it was, that's not the process, that in this emergency department, the charge nurse called the physician. And then she asked me what I had called for. And this is all happening very loud. I'm so new. Do you know that feeling like you want to cringe and die? Patients and families. This is a huge area. Everyone's staring at me. She's kind of yelling at me, but not really yelling. She's just loud by nature. I'm quiet by nature. And I think that contradiction made it even worse. And saying that, what's wrong with the patient? She had looked after the patient herself the day before, and that patient was fine. He was no different than he had been the whole day before, blah, 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 blah. And she would have to cover for me with the doctor. And so then I was humiliated, of course, but also still thinking, really, this patient was this sick, but I'm also new. And I had come from a very specialized surgical unit, and I had not looked after a lot of cardiac patients, although I recognized this was a deteriorating patient, but then she's telling me he's not. And I just remember thinking, I don't know what to do. So she talked to the physician for a minute, got off the phone. They had a big laugh. I had heard the laughing. And then she told me, luckily I covered for you. And the doctor just said, next time you take the patient's blood pressure, don't put the cuff around his neck. Ha, 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 ha. And I just remember feeling like trapped, right? And I guess now as a nurse, I wouldn't be trapped. None of that would unfold. Oh my gosh, I don't care what anybody thinks. I advocate for my patient. I get the right care for my patient. I couldn't care less what somebody is telling me to do or not do, because all that matters is my patient. But I was young, and that's not an excuse, but it's just, I think it gives me insight into, as we move through our careers, what things feel like. And so the charge nurse for the entire emergency department happened to walk past, and she said, "You look upset, or you look worried." I said, "I'm really worried about my patient. I've been through this. Now they say the patient has a bed. They wanted me to transfer the patient upstairs. I can't call and give a report on this patient because I think the patient's unstable." That was a lot for me to even say, to make that assessment, because everybody, in particular, this authority figure who was a permanent charge nurse in that area, was saying the patient was perfectly fine and had told the doctor. The charge nurse for the entire emergency department went in to see that patient, who was just in a cubicle behind us, and called out, "I don't know what everybody thinks is going on. This patient is having apneic spells." So we had to immediately start moving that patient to the resuscitation room because he needed to be intubated and taken up to the ICU. Terrifying event. And as we were moving, well, it wasn't terrifying to move him to the ICU, but that whole thing, that deterioration happening and feeling so powerless. But the point of this, I think, for me, is as we were moving the patient to the resuscitation room, that the charge nurse who had stymied me said, I can't believe it. I can't believe I missed it. I can't believe I didn't see it." And she looked at me and very sort of sternly pointed her finger at me as I was on the other side of the bed pulling it, and said, "And you are equally at fault because you should have fought me harder." Now, back then, many decades ago, I just hated her. That's not a good reaction, but that's a human reaction. Now I say, yes, you are right. Yes, that doesn't mean I like you more, but yes, you are right. I should have fought you more, because you don't own knowledge just because you're the charge nurse. I need to do my job, even though it's hard. Lots of situations are easier, but that authority bias is a really risky one, because again, patients can run into trouble and we're not there to help them when we're following somebody else. This is such an interesting one, this idea of action bias. So when we're in a situation where you can either do something or do nothing, you just don't know, you tend to do something. You feel kind of helpless. You feel that you need to take some kind of action, whether or not it's a good idea. A funny one that I always think is when a patient is crashing and their blood pressure is dropping, and we're doing a whole bunch of other things, and it's not helping the patient. You're running your drips, you're doing a whole bunch of things. Often I feel so powerless. I feel like putting the patient in Trendelenburg. Now, Trendelenburg, you remember, is a position where the head is down and feet are up. We used to use that all the time to try to bring somebody's blood pressure up when they were unstable. It doesn't work. It's not effective. The theory behind it is old thinking. We don't use it anymore. But when you're in that situation, and I feel so powerless, like what else can we do? It's very hard for old nurses like me not to say, should we put them in Trendelenburg? There's no evidence. But it's that idea, do something or do nothing. We lean towards the doing something. Another example is my mom was just recently in the hospital. And while she was in for one thing, she had what was either a stroke or a TIA. And the lead for the stroke team called me to say, we're in a situation, your mom has right-sided, she's not moving her right arm or her right leg. She's ignoring her right side. She's not able to speak. And the question is, do we give her thrombolytics or not? And here's the benefits and here's the risk, and you have to make the choice. And it was hard, right? It's hard to know if this is a TIA and it all resolves, that's great. But if it is a TIA, this is pretty significant for just a TIA. She had previously had a TIA, which was very mild, but it's pretty significant symptoms for a TIA. But there's also huge risk with giving her thrombolytics, like about a 6% risk that she's going to have a bleed from those thrombolytics. So do you fall to the side of doing something or to the side of doing nothing, even though the patient is symptomatic? And a lot of factors come into that decision-making process, but it's a really good example. And every situation doesn't resolve itself the same way. But that idea of when you're deciding do something or do nothing, that we tend to, by human nature, think I better do something. Ask yourself, is it going to lead to a better outcome? What are the risks with that? Is it going to lead to a better outcome? Framing bias. Oh, this is such a good one. Framing bias really affects us in sort of subconscious ways a lot. And it's really related to how information is presented to us or how we process information. And a really good one is this, I've got a quote here, but something like this. And I give you an example. The guy in room 4 came in with an alleged headache, got tattoos everywhere and smells like a chimney. He looks like a drug seeker to me. Does that influence your thinking as you walk into the room to assess a patient who says they have an excruciating headache? What if he is a drug abuser, does that mean he still doesn't have an excruciating headache? The point of how we frame information is really critical. And this is critical not only for you as a receiver of information, that you filter out the biases. So there's no evidence that this person is drug seeking, that's somebody's opinion. Those biases, those inherent biases, can be so very problematic. And we see them in lots of ways. We see them with ageism, we see them with racism, we see them in so many ways, those inherent biases. But in particular, when we're conveying information and when we're receiving information, we need to push out those framing biases because they are deadly. So let's say this person is a chronic drug user and this person did come to the emergency department seeking drugs because he really does have an excruciating headache and he really does have a subdural hematoma, right? So just because other things may be part of that person's context doesn't mean they actually don't have that medical emergency. Additionally, you don't know from the outside of a person what their life is like, who they are, how they behave, their health history. Observation of a person from the outside can lead to a lot of assumptions. So that framing of the information that we collect and communicate is so important. Yes, this is such a nice one too, ambiguity bias. And this is where, and think about it, it makes sense. We tend to favor the options where we know the outcome, we know more about what the outcome might be, over those which we don't. And so what this bias does is it really stifles new approaches, trying new things, because we don't know how they're going to work out. Now, often in medicine, we do clinical trials and other things to determine what the outcomes of a new approach might be. But sometimes we don't have time or a situation is emerging and we may have to make a decision in the moment. And what we know is that we tend to favor a path that we are familiar with than something we don't know. And a really sort of that idea, this is the way we've always done things around here. A really good one is this idea of intubation or non-intubation in the context of COVID-19. In the early days of COVID-19, everyone was being intubated. We were familiar with that outcome. We knew how to intubate. We knew that under these particular conditions of acute respiratory distress and desaturation, that we would typically intubate a patient, give them a rest, and we would be able to extubate them hopefully after a period of time. What we found over time was that we were not able to extubate those patients, and those patients eventually, the patients who were intubated were not surviving. And ultimately, they moved to a different approach that involved proning or placing patients on lying on their stomachs for 23 out of 24 hours a day, almost exclusively, so that their lungs could open further and we could get more air in, and it would decrease that respiratory effort, and not intubating the patients as much. Obviously, if somebody's going to have a respiratory arrest, you need to make good judgments about that. But that idea of following what we know, even if it may lead to a bad outcome, versus taking an unfamiliar path, is an important one to consider, and also to balance that in healthcare, doing something where we're not completely sure of the outcome is atypical. And so moving to this proning versus intubation, what happened in that situation is that we collected enough anecdotal information about superior outcomes that it became something that people, and it had been studied in lots of different contexts, that it became an option that people tried and developed more information around. But ambiguity bias is a really important one, that we tend to follow the path that we've gone on before. So where does all of this lead us? Well, it's really important to know that we follow data, right? We always look for what is the data, and always asking, and is there more information? So that I don't have that tunnel vision. Is there more information? And that requires that we have that stance of inquiry, keep our eyes open, always asking, what more, what more, what more? What am I missing? Trust your intuition, trust your hunches for sure, but also ask yourself, what's influencing my thinking? Right? Did somebody communicate in a way that's influencing it? Am I seeing cues that are influencing my thinking? Is this reminding me of a situation so much that I'm not opening my eyes to other things? So what's influencing my thinking? Every once in a while, do you ever hear, one of the best ways that family physicians can work with their patients is every once in a while, have their patients bring in all their medication, that big shoebox of medications, pour it out on the table, and then start fresh. Look at all the medications that they've accumulated over time, the new prescriptions, and say, what does this patient really need? And let's start fresh. We need to do that with our own thinking too. How can we start fresh? And so that idea of periodically stepping back and saying, what do I have, right? What's going on with my patient? Learn to develop your own repertoire of questions that allows you to gather information and come to answers that are not predetermined. So for me, some of the questions I might ask a patient or myself even, is there anything at all about you or your situation that would be helpful for me to know? Instead of saying, do you want, do you have any pain? Blah, 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 blah. Do you have whatever questions that are very specific questions, the yes or no, or the specific ones, always asking that question. Is there anything else I need to know? Is there anything else that would be helpful? And that really opens it up to a lot of information. Is there anything more you'd like to tell me? And that's so critical too, to make sure people feel heard, but also I may be on one path. Remember those thinking biases. I'm going down one path and somebody has a tiny tidbit of information that is going to make me say, wait a second, there's something else that's going on here. A really good question for me. Does anyone else here have more information? Does anyone else here have any other ideas? When you're in a code, and this is my own personal preference, and I have seen it used for decades, the last question in a code from the code leader should be, does anyone else have any ideas before we call the code? Right, so we've gone through the ACLS algorithms, we know what we're doing, we've worked through everything, we've been unsuccessful up to this point. Before we call it, does anyone have any ideas? That doesn't mean we'd follow the ideas, but we would assess them. And so that idea of opening it up to information. Ask questions. Don't ever be afraid to ask questions. Sometimes we're afraid to ask questions because it acknowledges what we don't know. But then the problem is if we don't ask questions, we still are in that state of not knowing. Make sure you can acknowledge your mistakes. Now, it's so funny. Again, I say now, decades as a nurse, an old oldie, I couldn't care less if somebody knows I don't know something. Of course I don't know things. So of course I would ask questions. Of course I would make mistakes. I don't take them lightly. I never take them lightly as a nurse, but my gosh, of course I would acknowledge I blew that. Sometimes with students, I have to say, I realize I blew it. Sometimes with patients, you have to say, or their families, I realize I blew that. And how you can be accountable and also move to that next step of says, and so where does this take us? Where does this take me with remediation with the patient or the family? How do we build trust again? Where does this take me in the future for myself? What do I need to learn or know so I don't find myself here again? And work at your own thinking strategies. The way you work out your muscles, work out your thinking. So one of the things I used to love to do when I was at triage, on those moments that it wasn't busy, I would sit at the triage desk and I would say to myself, okay, what if a man came in right now and he had a beer bottle sticking out of his eyeball? Although I did see that one time. What if a patient came in right now in labor and she started to have the baby right in front of me? What would I do? And what would I do? And work my way through those things, but also challenge myself with something I don't know. Some of those things I don't know. Some, I don't know. I'm trying to think of what would I do. But anyways, I think that idea of challenging your thinking, working on your thinking strategies and challenging yourself, just the way you go to a gym and work out, is so critical as we move our way through our careers. Well, I hope that was interesting for you. I do love talking about this because I love talking about nursing and high acuity nursing in general, but I hope that has been valuable for you. And on we go.